So good afternoon, Dr. Amar. I think first time we can, yeah, ma'am is also there. So thanks. Though we don't have any audience, but I think it was a good exercise to go through the literature and compile into a presentation for future purpose. So basically, oh, we are just rotating chairs. Actually, there must be multiple houses, na? Last stage. That's a problem. Uh, that I what was I saying just now that though there is no audience, but it was a good exercise to go through the literature and have some self learning. Yeah. Yeah. So basically, I prepared this presentation under these headings. So the main two objectives from endocrine perspective is that when and how we treat thyroid eye disease. That is one part. Like there are certain cases which do come us to us along with the hyperthyroid state. And the second important perspective is that how we treat the Graves' disease in the presence of thyroid eye disease. So basically, these are the four common presentations that a patient can of thyroid eye disease can have: clinically active eye disease, exposure keratopathy, globe subluxation, and dysthyroid optic neuropathy. The patient which tend to come to us are mainly, and where we are means mainly involved in the decision making is the either the patient is having clinical active eye disease or the dysthyroid optic neuropathy. Purely dysthyroid optic neuropathy patients usually come less directly to us, but may have coexistent clinically active eye disease. So the two other spectrum which I just mentioned, subluxation and the exposure keratitis, is purely basically an ophthalmologist zone from treatment management point of view. So this is what if we have a first time assessment, these are the points which we go through. Whether the patient is having pain, either spontaneous or gaze evoked, or there is a redness of eyelids, conjunctiva, swelling of gruncle, plica, eyelids, and conjunctiva. And we do all know that if the patient is having score of 3 or more, then it's called active Graves orbitopathy. If it is less than 3, then it's inactive Graves. And if we have a follow-up visit, then these 3 points come into picture. Proptosis, if there is an increase uh, in dimension by more than equal to or more than 2 mm, then reductions, and then the decrease in visual acuity over 1 to 3 months. So it's important for in the first visit to also document what is a baseline proptosis parameters, what is a baseline ductions, what is a baseline visual acuity, because only then it will be meaningful to apply this score at follow-up. And the scoring system is a little bit different. When we have a 10 point assessment, then it is less than 4 is inactive, and 4 or above is an active Graves orbitopathy. So along with the activity, is equally important to have a look on the severity of Graves orbitopathy, and predominantly these are the four parameters on the basis of which one decide whether it is a mild or moderate to severe Graves orbitopathy. So lid retraction, soft tissue involvement, what is the degree of soft tissue involvement, again the proptosis level compared to the baseline, and the diplopia, whether it is present or what grade of diplopia is present. On the basis of these cutoffs, it is decided whether it is mild, moderate to severe. And usually when there is an active moderate to severe Graves orbitopathy, usually immunosuppressions are required to control the picture. Again, as we go through the literature, most of the almost all articles have different endpoints for assessment, so it become very difficult to compare head to head the evidence generated by the one study against the other study. So to standardize the parameters, this is what UGOGO has approached. One has to assess both activity and severity parameters, and there are standard response parameters, and if there are 2 out of 4 parameters are basically under control at follow-up, the patient can said to have a response to treatment, and without worsening of any parameter in the contralateral eye. So the third thing is a sight-threatening eye disease. In the sight-threatening eye disease, again, these are the three parameters, three disease manifestations which come, and most of the cases are basically then surgical candidates to prevent sight loss. These are the risk factors. If it is a male, gender, age more than 50 years, patient has got some radioiodine treatment for thyroid in the past 6 months, or there are some severe features to suggest orbitopathy involvement like lag of thalamus, motility, then the patient is at high risk of sight-threatening disease, and these patients need to be followed up under regular intervals, maybe 4 weeks or even like less than 4 weeks, 2 to 4 weeks, or depending upon the risk factors, number of risk factors present in a particular patient in this baseline situation. So this is a flow chart from a UGOGO guidelines, which says that intravenous methylprednisolone is a standard of care. What we need to know regarding that steroid path is whether we want to give IV steroids, whether we prefer oral glucocorticoids, then what should be the regimen, whether it's a 4.5 gram versus a high dose 7.5 gram regimen, or whether it has to be give singly or by combining with the mycophenolate. So these are the three things which goes into decision making at the first assessment visit regarding first line institution of immunosuppression. So what the evidence says that this is a trial and published in 2005. So basically what we use in our clinics is a once weekly IV methylprednisolone, zero point 0.5 gram every week, and then 0.25 gram every week after completing the 0.5 gram course. So it amounts to 4.5 gram. So this regimen, which is a standard of care nowadays, is basically originated from this trial published in 2005. So what they did is they compared the 4.5 gram dose to the 4 gram dose given orally over 3 to 6 months, and then they saw that the primary composite endpoint was actually better when IV glucocorticoids were used, and there was a marked difference, means it's nearly like 50% more response what you see with the oral glucocorticoids, and that is why the IV glucocorticoids is preferred over and above the oral glucocorticoids. So this is one very clear message, because we do encounter patients which comes from the periphery, where the patients are on oral glucocorticoids rather than the IV glucocorticoids. And these are the individual response parameters. So clinical activity score has improved. It's dramatically 5 to 2 compared to 5 to 3 in oral glucocorticoids, and similarly proptosis, diplopia, optic neuropathy, each of the parameters had a better response with the IV glucocorticoids compared to the oral glucocorticoids when dose was comparable between the two arms. It is not important to have look only in the efficacy, but even side effect profile is very important. So we do in endocrinology see cases where the exogenous glucocorticoids are given. So in general, if anyone has been given 3 weeks or more of 7.5 gram of steroid, the chances of adrenal suppression and the Cushingoid habitus chances increases. So giving 4 to 6 months obviously puts patient at a high risk of having Cushingoid features and adrenal suppression, and which take years to recover. And that years to recover basically predispose patient to have adrenal insufficiency. So most of the patient do come in adrenal crisis if not replaced after having a long course of oral glucocorticoids. It's become very tough from endocrine perspective to deal with such patients. So luckily we don't see such problem with the IV glucocorticoids. So even with the side effect profile, if in this trial it is only 70% with the IV glucocorticoids compared to the 51% oral glucocorticoids, which again gives a very strong message that IV glucocorticoids should be preferred over oral glucocorticoids. Then second point comes with the three different doses. What should be the dose that should be tried? So the first trial gave the dose of around 4.5 grams. So this group, what they did is basically tried the dose which is half compared to the standard dose, and a little bit higher dose compared to the standard dose. So three doses were compared, and the response rate was nearly comparable with the 2.25 and the 4.98 gram dose compared to the high dose, 52%. So obviously, if you give the higher doses in a patient who is active, the response rate will be high. But simultaneously, the side effect profiles is also higher when you give the IV steroids in higher doses. So it's not means recommended to give IV high dose in all patients, but in certain situations, as we see ahead, the patients can be put on a higher doses, that is 7.5 gram compared to 4.5 gram from the beginning. This is again an important trial recently published in the this Lancet Diabetes. So this what they did is to compare the IV glucocorticoids along with IV glucocorticoids plus mycophenolate for 6 months. So what they have seen that response rate with the combination was better at 9 months when combination of the drugs was given as compared to the IV glucocorticoids. So this is what has gone into these three trials has basically feeded into this UGOGO flow chart. And what the UGOGO now states, initially it was 4.5 gram IV glucocorticoids alone, that was a standard of treatment. Now what they says is that from the beginning patient can be put on IV glucocorticoids plus mycophenolate. And if mycophenolate and this combination is not feasible, so one can be put on a high dose glucocorticoids, especially if the patient is having diplopia, severe proptosis, and severe inflammatory soft tissue changes. So what we practice at AIMS is to stick to the 4.5 gram dose and use mycophenolate or glucocorticoids depending upon the high dose glucocorticoids or low dose the standard dose glucocorticoids along with mycophenolate on case to case basis. So these are some precautions which has to be taken when patient is on IV glucocorticoids. Single dose preferably should not exceed 750 milligram. Cumulative dose should be less than 8 gram per cycle. Consecutive day therapy should be avoided. Infusions should be performed slowly, 1 to 2 hours under strict surveillance. One has to rule out infection by doing a TLC count, cardiovascular risk factor, significant hepatic dysfunction and viral hepatitis before giving IV steroids, and hypertension and diabetes shall be under control. These are the contraindications: recent viral hepatitis, significant hepatic dysfunction, severe cardiovascular morbidity, and psychiatric disorders like severe depression, psychosis are absolute contraindications for IV high dose steroids. There will be some patients who partially respond at 6 weeks. If there is a partial response, one can continue with the full dose regimen. But if there is no response and there is a deterioration, one has to switch to the second line treatment strategies. So what comes in the second line treatment strategies? Either a IGF-1 receptor monoclonal antibody this against IGF-1 receptor, teprotumumab. Then there is an orbital radiotherapy. Then there is a rituximab which depletes the B cells, or there could be anti-IL-6 receptor monoclonal antibody which is tocilizumab. So these are the 4 or 5 reagents which are used in follow-up as a second line options. So what is an evidence? Teprotumumab basically has been compared to the placebo as a first line agent, and there is an excellent response. Anything between 50 to 80% in the parameters is usually good in this setting. So teprotumumab has shown good results, but it has not been compared head to head with the IV glucocorticoids. There are some concerns. That is one, lack of head-to-head data with IV glucocorticoids, lack of data as a second-line therapy. Then there is a high degree of hearing loss that is seen with the teprotumumab, hyperglycemia obviously, but the cost of regimen is more than 2 crores. So availability is, it's only available in USA, it's not available anywhere outside USA. So this huge cost and availability is one of the major concern against teprotumumab. Tocilizumab, again there is a significant impact on clinical activity score, proptosis, diplopia, but it is mainly used as a second line. So as a first line agent, we don't have any data on tocilizumab from RCTs. Doses and monitoring: whenever you are using mycophenolate, teprotumumab or tocilizumab, so one has to monitor with the fasting blood glucose profile, LFT, lipid profile, and have a look on the conditions which can get worsened by the this drug, second line drugs. Orbital radiotherapy is not a standard first line therapy, but it is usually given when along with the glucocorticoids when the patient has a significant diplopia. So when it is preferred, 20 gray in 10 days is delivered, and it should be avoided in patients with a hypertensive retinopathy, diabetic retinopathy, and age less than 35 years. Rituximab, again very less data. So, but rituximab has been shown to decrease the clinical activity score significantly when given even in patients who have received the first line IV glucocorticoid. So, this is rituximab is a preferred drug by us when the patient is not responsive to the IV glucocorticoids. So, 500 milligram single infusion or 1000 milligram 2 infusions, what people have tried in these scenarios. So in second case scenario, IV methylprednisolone high dose can also be given if it is not partially not responded to the first course of methylprednisolone. Oral prednisolone we usually do not prefer. Orbital radiotherapy if there is a diplopia, teprotumumab is not available. So what could be available is rituximab and tocilizumab. So there is more experience at AIMS with the rituximab than the tocilizumab. So as a second line therapy, this is what we prefer as a means if patient is not responsive to IV glucocorticoids. Rundle curves, we all know that if patient has a spontaneous recovery by some time, but it can result in a significant residual damage. So it is better to pick patients early, preferably within 9 months of presentation, and treat to means decrease the side effect. So this is just a chart, like just one has to consider a lot of conditions without before deciding any particular therapy has a second line. Site threatening, just a slide on site threatening Graves orbitopathy. It's a standard. Matlab you give like three doses of either zero point 0.5 gram or 1 gram alternate day over 1 week. If patient is showing some response, it can continue to second week. But if there is a deterioration after even within 1 week, it is better to do orbital decompressive surgery to save vision. For management of hyperthyroidism in presence of thyroid eye disease, so if the patient is having moderate to severe active disease, radioactive iodine is to be avoided. In mild disease, if patient is having inactive, it has to be treated by radioactive iodine ablation if used as a permanent treatment modality under steroid coverage. So antithyroid drugs can be used in any situations. So to wind up, one has to look for the non-pharmacological measures also. One has to assess for the activity severity. If it is mild, watchful monitoring can be sufficient, and oral glucocorticoids is acceptable in certain situations in mild thyroid eye disease, but mainly it's a watchful monitoring. For moderate to severe thyroid eye disease, IV glucocorticoids is a preferred therapy. Teprotumab is a again first line agent that can be used, but it is not available and costly. So if it is a without diplopia, IV glucocorticoids alone can be used. If it is along with the diplopia, either high dose IV glucocorticoids or should be combined with the radiotherapy. If patient is not responding, then tocilizumab and rituximab are the alternatives, second line agents. So thank you for patience.
Thank you, Dr. Yashdeep. It was really a wonderful talk, I must say. And you have answered almost all my questions, that I came with. And a very systematic way you explained each and every important, points which we should know when we are managing such a challenging situation. It's a very challenging disease, I must say, even for the surgeon to have a good, functional and aesthetic outcomes. So just couple of questions I have still. One is the UGOGO classification also talks about the selenium. So do you get some routine selenium serum test also done or consider selenium therapy?
No, we
In our
usually
country, it's so. What is your
no
take on
selenium
this?
actually. Even there is some drawback because that trial has been done without evaluating any selenium status. So again, there is really a doubt ki whether that dose has actually means resulted in some improvement or not. But in our practice, we are not doing selenium, and neither we are supplementing selenium.
All right. And second question is, how many patients have you seen with a recurrence of disease, say after a year or so, coming back with the active stage
I think
again?
we do not have a record, but what being a tertiary care hospital has, you are part of that evaluation. So we do see patients who have already like been treated outside, partially treated, in between oral glucocorticoid started, and then well, multiple sort of regimens. So I think we do get 2 or 3 patients a month with a recurrence which are very troublesome. So in that there is a challenge, means what then we do is that use a high dose IV glucocorticoids if they have like received partial glucocorticoids, means therapy in the past, and sometimes combined with the mycophenolate. Now we are using oftenly using mycophenolate along with that, and I think couple of patients on mycophenolate have shown good response. So
Right.
I think
Okay. Thank you so much.